Good evening, everyone. Thank you for tuning in for today's lecture, which is part of the Women's Surgery Interest Group lecture series. We're happy to have you. My name is Jan Ghanem, Med3 representative, and I am honored to introduce Dr. Albert El-Hajj as our guest lecturer. Dr. Albert El-Hajj is an assistant professor at the American University of Beirut Medical Center. After graduating from the St. Joseph University in Beirut, he completed his robotic and minimally invasive surgery fellowship in Paris at Montsouris, Henri Mondor, and St. Joseph Hospital. He joined AUBMC in July 2013, where he founded the Robotic Urology program. He was also instrumental in developing the Endourology program at his institution with his expertise in laser enucleation of the prostate for BPH. In March 2018, Dr. El-Hajj introduced the aquablation procedure and performed the first cases in the region. In today's lecture, Dr. El-Hajj will be talking about urologic emergencies, thoroughly going over the most important and common themes. Before we start, kindly make sure your microphones are muted. All throughout the session, feel free to type in questions or concerns in the chat box. Thank you. Dr. El-Hajj, the floor is yours.
Thank you, Jan, for the introduction. And I'd like to thank Women in Surgery for their invitation on this very interesting topic today. It's a little bit, something that we're seeing often nowadays, unfortunately, in our country. I'm going to try to keep you, interested in the presentation. I know we got used now to the, having these, as webinars. Used to like the, face-to-face interaction. This is what we can do now, and I hope you will enjoy it. Are you seeing my screen?
Yes, we can.
Okay, fantastic. So we're going to talk today about the trauma in urology, diagnosis and management. As you know, it's a very wide chapter here because you have many organs in the urology. So starting with the kidneys, then the ureters, the bladder, but also the genital tract, the urethra, the penis, and the scrotum. So I'm going to start with a case here, and it's a 47-year-old who presented after a motor vehicle accident to the emergency room. He is conscious, he's stable, his vitals are stable. So the patient is stable, his is clear, blood pressure stable, he's fully awake. He has a left flank hematoma. So he's complaining from left lung pain and gross hematuria on admission. On the physical exam, you have an ecchymosis on the left flank. There is no blood at the meatus and normal digital rectal exam. So he is hemodynamically stable. He has a blunt trauma, a flank trauma, and left flank pain, hematuria. So what would you do next? A question to the audience. If you want to, answer by chatting on the chat, and we'll see your responses. Actually, Jan, if you can see the chat box, because I can't see here. If anyone has a question or you
Absolutely.
have any questions.
So they're saying CT scan.
CT scan, okay, fantastic. So this is what we're going to do, a CT with contrast, of course. So before we go into that case, I'm going to continue and talk a little bit about renal trauma. So this is the most common injury in urology. 80% injuries are renal, 10% are injuries of the bladder, and 10% are the other organs. And as you know, or you might not know, maybe it's only 4% of trauma that targets the GU organs. So 72% are usually minor, 10% are moderate, and 11% are major. So we have 11% major trauma, and mainly this is the kidney trauma that are the most important. And it's important to know that more than 90% are managed conservatively. So a lot of conservative management in urology, and we'll talk about that. as we go through the lecture. So as you know, I said we have the and the lower urinary tract. So the upper tract, which I want to start with, are the kidneys and ureter. The kidneys usually the retroperitoneal and space, and they're well protected by the ribs. They're well protected by the back musculature, and the perinephric fat plays a very important role as well. And as you know, the right kidney is lower than the left kidney due to the presence of the liver. So the common mechanism are usually the motor vehicle accident, but also falls, direct blows, lower rib fractures, and mainly the decelerating forces that cause the kidney injuries. So clinically, in the urine, and that's the hallmark of injury to the genital system, but it is not specific for injury location or severity. So the physical, the history is important. The history of the trauma is very important. And of course, when hematuria occurs, you have to examine the whole urogenital system. And as you said, a CT scan, but the correct answer, of course, is CT urography. So a CT with contrast and a delayed phase, which is very important. So as I said, the most reliable sign of injury to the kidney is hematuria. But sometimes, in some of the injuries, you have renal artery thrombosis or complete pedicle avulsion. So you may not have blood in the urine. We have to take into account certain criteria to do the imaging. And these criteria usually are hematuria, this is number one, but also microscopic hematuria with a hypotension, so systolic blood pressure less than 90. Okay, or in children, if the hematuria microscopic is more than 50 RBCs, so then you have imaging. But also in penetrating trauma, like bullet injuries or knife so sharp injuries, in these cases you have to do imaging, of course. So the CT, as we said, is the first line of imaging, but of course the patient has to be hemodynamically stable. If the patient is not hemodynamically stable, then, and I think you've heard it all over those lectures, then you have to go immediately, either to ultrasound, which can be done in the ER rapidly, and proceed to the OR. And in the operating room, here you have to, when looking, usually, when you have other, trauma, for example, in bullet injuries, you have other trauma, bowel and chronic injury, etc. Then you'll have to look at the peritoneum. And if you see a pulsating hematoma, then here urinary tract must be investigated. In this case, usually what was recommended is a one-shot IV. So you give IV contrast to the patient, and then after 10 minutes, you take an image, just an X-ray. And this will tell you if the patient has any urinary trauma, extravasation of urine, but also it's very important to check the other kidney, because you never know when it comes to you, you don't know the patient comes in an emergency setting, and you not have another kidney on the other side or an atrophic kidney. So this is important in management. And these are the grades of urinary injury. As you can see, the grade 1 is just a contusion. The grade 2 is minimal laceration with hematoma that's confined. A grade 3 is a bigger laceration, so more than 1 centimeter, but does not reach the collecting system. And the hematoma is bigger in that case. So the grade 4 are injuries where the laceration extends into the collecting system, into the medulla. So these injuries are more severe. We can also have, injury to the main renal vessel, artery or vein, but the hemorrhage is contained. The grade 5 is a shattered kidney, completely shattered, as you can see in the image here. And this is a very serious injury in that case. So the management of these cases, the first is the non-operative management. And why is this very important in the kidney? Because as I said, the kidney is in the retroperitoneum, and usually these hematoma or injuries are contained and they can stop on their own. When you open the retroperitoneum, then you can have uncontrollable bleeding, and in that case, you will have to resort sometimes to nephrectomy. While those patients could have been managed, conservatively, or angioembolization. So we'll talk about each. So this is here, how to take, if you want, the management of those patients. So a patient comes with a blunt trauma, with hematuria, but no shock. You do an imaging, and then if the patient is stable, you can follow up clinically. So there is no issue here. If the patient is stable, so he's in shock, then you have to examine abdominal exploration and assess for retroperitoneal hematoma. If it's a pulsatile or expanding hematoma, then you have to explore. If the patient is stable, with resuscitation, then you can do an abdominal CT. Grade 3 to 5 usually can be either explored or angioembolized, so do embolization in those cases. The same for penetrating injury, but penetrating injuries are usually more severe, and in those cases, we might intervene for other injuries, associated with the kidney. So overall, 90% of injuries, as I said, and I say it again, can be managed successfully just by operative management, even the high-grade injuries nowadays. This is an example here where we have to do angioembolization. So in case we did an angio-CT, and you can see here a bleeding from a vessel in that case, and here it is indicated to do an angioembolization, and with the angioembolization, you can selectively size that vessel and protect the kidney and save the kidney from an nephrectomy and save the patient as well from bleeding. So this is one thing that you could do, and it is very commonly done now. We even do it, after surgery, sometimes after partial nephrectomies where the patient can bleed after the surgeries, and it's a very good, so our radiologists are very experienced in angioembolization. Absolute indications for surgical management, as I said, are hemodynamic instability, no or response to resuscitation, expanding pulsatile hematoma, suspected renal vascular pedicle avulsion, you need to repair the kidney, there is no other option. And also in some cases, and we see mainly in the deceleration or sometimes the bullet injuries, the uretero-pelvic junction avulsion. So the uretero-pelvic junction is completely avulsed, and here we need to reimplant the ureter. So you go into those cases, usually it's by a big abdominal incision, medium line incision, abdominal transperitoneal, and you open the mesentery here to access the renal vessels. So we don't open the retroperitoneum first. First, we need access to the vessel, to the main vessel. So, and we put vessel loops around our main vessels. That if we open the retroperitoneum and there's not bleeding, then we can have control of the vessels and put clamps on our vessels and control the bleeding in order to repair the kidney. So very important to have vascular control first. These are examples, of kidney injuries. And the first image here, which could be a penetrating injury or a laceration. So you can resort to a nephrectomy. So remove the whole part that's shattered and reconstructing the kidney with reconstruction of the collectum, and then reconstruction doing a nephrography and putting an omentum flap to avoid contact with the other organs, but also to avoid complications. It's like a partial nephrectomy. In that case here, where we have a injury, also you can do a nephrography to repair the kidney and use hemostatic agents, like, for example, here they use the gel foam. So come back to our patient. We didn't mention the labs. So his hemoglobin was 10, creatinine is normal, and he has numerous RBCs. So as you said, we did a CT scan, and this is his CT here. Can anyone tell me which grade this CT is, or this injury?
I think it's a hard question. It's not very clear for us.
Yeah, I did it on purpose.
They're guessing if it's
okay.
Okay.
Okay. So it's a 4 because we have two things. One, there is a deep laceration. Okay, and two, it seems that there is extravasation of contrast from the renal vessel. So we have a renal vessel injury. It's not a grade 5, so it's not a complete shattered kidney, you see a very large hematoma and kidney. Okay, so what would you advise in that case? What would be your management? I think I have another image. Yeah, I have another image here. So this is here where you see the vascular flare, if you want to be of contrast. And also there's a very important finding on the CT scan. So the other finding is, as you can see here, an atrophic kidney on the right side. So here the decision is important in that patient. Yes.
I'm guessing angioembolization.
Okay. So correct, that's the correct answer. And okay, so someone is saying surgical, someone is saying preserve as much of the kidney. Okay, so yes, so surgical exploration, we would wait on this patient because only the kidney is injured and he has an atrophic kidney on the other side. The risk of doing surgical exploration is here you will end up losing the kidney. Okay? Because once you open that retroperitoneum, he will bleed and you will end up with an nephrectomy. So expectant management, conservative management is one, and angioembolization is also a valid option, if the patient continues to bleed. In that case, they waited on the patient, they hydrated him, they transfused him, and he was in the ICU for monitoring, he was stable, and he was then transferred to regular floor and discharged from the hospital. I got an almost similar case, but with a grade 3 laceration that came after the Beirut port explosion. I don't have the imaging now, but so this was the patient that was, he was under for a few days, and his only the kidney injury, a kidney laceration. Of course, he had a lot of dehydration, but this was his only injury. We monitored him, and now he came for a 1 month follow-up, and his kidney is completely fine. The laceration has completely resolved. Not 1 month, actually. It's been like around 3 months or 4 months from explosion. So he just came to see me last week. So his kidney is fine. So really, conservative management. If this is something that you need to learn from kidney management, this is it. Let's move now to the ureters. Okay, so ureters a little bit, so it's rare. We rarely see them in trauma. We see them a lot in surgery, as surgical complications. So they're 1 to 2.5%, but we mainly see them in, general surgery with OBGYN, with major surgeries, major abdominal surgeries with big tumors that are sometimes invading the ureters. But sometimes, with hysterectomies, you can have heat injury to the ureters, and we see those, we opt for those quite often. Sometimes they're covered late. So after the surgery, these patients are, they found out they have hydronephrosis and completely obstructed ureters due to mainly heat injury and delayed stricture or stenosis of the ureter. But also we can see, external trauma, bullet injuries, and stab injuries. So these are also we can see them often. Most of the injuries to the ureter are penetrating, 95%, and only 5% are blunt injuries. And also, this is a classification. Well, it's a little bit interesting. I mean, not very useful for the management, because mainly, if you have a transaction and you have a urinary leak, usually you are exploring those patients, so you will repair, or you will do endoscopic management in those mild cases. So in the more severe cases, then here you have to do surgical intervention. So, as I said, 3% are gunshot wounds, and they will have significant concurrent injuries and a high degree of mortality because they have other injuries. If it hits the ureter, it means it has crossed several other organs that are vital. Okay, and hematuria also is there, but it's non-specific. It can occur in absence of hematuria, this injury. So you have to have a high index of suspicion in those cases after penetrating trauma. Radiography is indicated here, and surgical exploration is the most accurate diagnosis. Now, I recall a case where, I was told by general surgery, it was like 4 or 5 years ago, and it was a patient coming from outside Lebanon, an Iraqi patient who had a gunshot wound, came from outside the country. He had the first intervention, the first surgery. They did, the bleeding. He had bowel anastomosis. He continued to have leaks from his bowels. And so he came for the exploration, and he had abdominal pain, and the collection. So during the exploration, the general surgeon called me, and we were not able to find the ureter. It was very difficult. It was a second surgery. Everything was stuck. And I did, in that case, one-shot IVP is one option. In his case, I did a retrograde urethropylography. So we inserted a cystoscope from his urethra, and we injected contrast from a urethral catheter through the ureter, and he had a complete avulsion of the ureter. And because we couldn't find it, we inserted a guide wire from the ureter, so through the urethra, through the ureter, and by looking into the into the abdomen, we were able to find the ureter, and we did the repair. In those cases, it's important to look at the vasculature of the ureter, because of the gunshot wound can cause a lot of charring and burning. You have a lot of tissue. Also, the tissue is shape. This is an example here. This is another patient who was shot in the beka, actually. So a gunshot wound that came through his back, and the bullet got stuck in his abdominal wall here. And if you can see, the bullet crossed here the peritoneum. So this is mainly the trajectory of the bullet. Okay, this was so this was a wound. The patient, when he came, was unstable. At the beginning, they resuscitated him, and they were able to do a CT scan. Maybe I would have done differently in that case, but he was stable enough to be put in a total body scan with contrast. And as you see, the case is spared, but you can see a lot of haziness happening here around the ureter. So they explored the ureter, and they found a complete urethral transaction. The ureter was repaired with an end-to-end anastomosis. The patient had a drain. After 2 months, he came to see me for a second opinion because I'm still giving urine. A CT urography, and still have a small urinary leak. In this case, really, and since the drain was giving minimal amount, I advised him to wait because he already had a repair. It was not a perfect repair, but I understand that due to the circumstances and how the patient was, presented, the presentation, this is what they could do. And now, the patient tells me that the drain is not giving a lot. I'm scheduling him for another CT to see if there is still a leak. And if there is no leak, then I will remove his urethral catheter. So as you can see, some of the cases, can be, if you have a partial laceration that's remaining, can be managed conservatively, So with just drainage or endoscopy. It's important to know where the urethral injury is. And this will tell you what kind of care you will do. So if it's in the upper third, usually these are the most difficult injuries, like this patient, you have to do direct ureterostomy, or in some transureterostomy, so you re-implant the ureter on the other side. Honestly, I've never done that, and I don't like to do this because then both kidneys will be dependent on one ureter. And if the patient has a stone or any obstruction, then both kidneys will be shut down. If it's in the mid ureter, here the option is either direct ureterostomy or transureterostomy or a Bowari, and I'll talk about the Bowari flap. If it's in the lower third, here you can do direct re-implantation with what we call a Sawa switch. I also describe the technique, and or a flap as well. Important rules, as I told you, and especially in bullet injuries. So you have to mobilize the ureter, but not devascularize, so keep the adventitia, to keep the vascularization. The debridement is very important, especially in gunshot wounds. Remove all the tissue until you have a bleed. Spatulate and do a good anastomosis tension-free is very important, and put a double J stent inside. Usually I use PDS 4.0 or 5.0 sutures. Retroperitonealize the ureter, important. Do not turn the ureter, and putting an ornamental flap in those injuries is also can be helpful, if possible. So these are the rules I described. So speculation and anastomosis here, and end-to-end anastomosis is putting double J stent. The double J here, you can keep it up to 2 months for the healing to take place. And when I remove the double J stent, I will remove it in the operating room. I will also, put contrast, do a retrograde ureterography to check that my anastomosis is fine. If it's not fine, still leaking, or I feel there is a stenosis, because this is one of the risks, I might put another double J stent and keep it for a few months as well. So this is what we call a Bowari flap. Bowari flap is actually when you have a loss of length of the ureter and you want to get that bladder close to the ureter to do a direct anastomosis. So you can stitch the bladder, so mobilize the bladder completely, anteriorly, but also mobilize the pedicle of the bladder, and the contralateral pedicle that has to be mobilized. Okay, then you put stitches on the psoas muscle. So you stitch the bladder on the psoas muscle, 3 or 4 stitches, and getting that bladder close so that you can reimplant your ureter in that case. Okay, your implant. So the other technique is the Bowari flap. The Bowari flap here is when you have really a very large loss of a long you lost from the ureter, and you have to reimplant it, and the bladder, even with the psoas, does not get there. So it's not going to get there. You don't want to do a under tension anastomosis. Okay, so here you will do an incision in the anterior wall of the bladder. It's like a flap, and then you reverse the flap posteriorly. So this is the anterior bladder, size it like a ureter, and then you anastomose flap with the ureter, and then you suture everything. So it's maybe a coincidence, but last week I did both a reimplantation, the psoas hitch, and this was after a gynecological surgery, and I've done Bowari flap, and this was done here, an open surgery in a patient who had a very large rectal mass invading everything, including the left ureter. And here I had to reimplant the ureter. Using the bladder after radiation therapy was quite impossible. In that patient, we couldn't reach, even with a psoas hitch. So we did a Bowari flap. You can see it here. This is the anastomosis, and that's the ureter. And double J stent. A Foley catheter is kept for 2 weeks, and the ureteral stent, as I said, for a couple of months, and then we'll remove it in the operating room. This is the transurethral ureterostomy. I don't like it, but it's good to have in your armamentarium, because maybe you have to do it someday, but usually it's preferable to reimplant the ureter, if possible, on the bladder or do a urethral ureterostomy, and not implant on the other ureter. Ureter. Now we'll move to the bladder. The bladder usually is well protected, and very, very rare to have a bladder injury. But surprisingly, you can see, especially with pelvic fracture, this is the most common cause of bladder injury, and they're associated with HHP, so to 95% of bladder injuries. But also, we've had patients with full bladders having a seatbelt injury, so their deceleration injury was a full bladder, and you can have a rupture of the bladder if it's full. But also, of course, direct injuries, gunshot wounds, or penetrating injuries also can happen. The clinically, so they with suprapubic pain or tenderness, you have fluid in the intraperitoneal fluid on or ultrasound examination. Usually the patients are unable to void or having a very low urinary output. Have clots in the urine sometimes, so gross hematuria. They can have also scrotal ecchymosis, and this is related to the pelvic fracture as well. And they have abdominal distension or ileus, especially when it's an intraperitoneal rupture. And this is why it's very important also to differentiate between intraperitoneal or extraperitoneal rupture. Why? Because extraperitoneal ruptures, if the patient is not going to be explored, then you can just observe the patient, okay, in the extraperitoneal rupture. And this is here with a cystogram showing how you see the extraperitoneal rupture. So it's a limited exploration of the contrast, not reaching the bone, and it looks like a flame usually. And this is extraperitoneal. And basically, even on the physical exam, sometimes differentiate because usually they have pain in their and tenderness in their lower abdomen, but not in the upper quadrants. So you have no peritoneal irritation. So usually it's conservative management. You put a catheter in. You can keep that catheter for up to between 2 and 3 weeks, depending on the level of the injury and the so how big the injury is. And then the orthopedist can fix the problem that they have. This here an injury that's intraperitoneal, and this is a CT cystogram. And so as you see, the contrast is around the bowel, moving around the bowel. Here you need to do a repair. So we need to do a repair because it's intraperitoneal, and usually it's a 2-layer repair, and you have to do a cystogram after 2 weeks to confirm that it has healed. Then you can remove your Foley catheter. So what about urethral injuries? The most common urethral injuries are the posterior urethral injuries, and these occur with pelvic fractures, usually from motor vehicle accidents or falls or industrial accidents. So usually it's a major trauma. And this is, for example, a straddle fracture here, where you have all the 4 pubic rami fractures. And here you have a rotational fracture, and they have a high risk of urological injury in those cases. And basically, in those cases, we might have a urethral disruption. So the urethra is completely disrupted. And the triad here, the clinical triad, is inability to urinate, there is blood at the meatus, and there is a palpably full bladder in those patients. On the physical exam, when you do a rectal exam, you have a high riding prostate because urethra has completely disrupted. So the prostate is higher. There's a butterfly perineal hematoma. And usually, when those patients is not, indicated, usually you should call the urologist before attempting to put a catheter. And basically, there's difficulty sometimes to insert that catheter. Sometimes a false tract, the catheter goes into the pelvic hematoma. So in those cases, you'll have to put a suprapubic catheter. This is the image. This is a ureterogram. Shows you the complete disruption, as you can see, of the posterior urethra. And in that case, this will be managed for now, put a suprapubic catheter, manage the fractures of the patients with the orthopedic team. And then when this is managed, then you can the problem of the urethra later. This is a fracture. This is an open book fracture when there is disruption of the pubis. And as you can see on the X-ray, the regular X-ray, you don't realize really the danger of those fractures like we see here in the CT. So on the CT, you see that bone has completely moved and has, injured the bladder in that case. Okay, so suprapubic cystostomy, this is the indication, delayed reconstruction. Sometimes attempt primary realignment, which is endoscopic. So we insert an endoscope from the urethra, but also an integrated flexible cystoscope from the bladder. And this is a good alternative in stable patients. It can be done after a few days. And it should be a brief attempt, not a long attempt, in order not to cause more damage and harm. And especially if you have a disruption and we are injecting fluids when we do these procedures, you might have extravasation of fluid, outside, and makes the problem really worse. So if this is successful and I am able to realign the urethra and the bladder, then we put a Foley catheter and a suprapubic catheter, so double drainage, long-standing 4 to 6 weeks. There is a risk in those cases of urethral stricture because of devascularization that happens in that area. So they might have a stricture. This is why we're keeping the suprapubic catheter in case they have a retention afterwards. Of course, if there is not a complete urethral injury, you can attempt to put a catheter gently. And if it doesn't work after 1 or 2 attempts, then stop and do not force. And you have always to check that the catheter is in with imaging, because as I told you, there is a risk of false passage. This is an example of the reconstruction at 2 to 3 months. This is a perineal approach. So we go through the perineum into the, the posterior urethra, and we find the 2 edges of the urethra, and these are reconstructed and anastomosed. There is a risk in those cases of urinary incontinence if the sphincter is shattered or cut by the injury, but usually not, but this might happen. And there is also a very high risk of impotence in those patients, and usually those patients are young, either from cavernous nerve injury or arterial deficiency, venous leak, or direct corporal injury. So it's multifactorial, but the patient has to know that after these types of injuries, they are at risk of erectile dysfunction. Anterior urethral injuries are rare. They occur after straddle injuries. They involve the bulbar urethra. They can also happen with direct penetrating injuries to the penis. You also see blood edematous, a perineal hematoma, gross hematuria, or urinary retention. Now I've seen patients with bullet injuries to the penis, and this can be quite devastating. But sometimes with partial injuries to the penis and only injuries to the corpus spongiosum and partial injuries to the corpus cavernosum. And I remember a case during my residency where this happened, and we were able to repair his corpus spongiosum completely, and also his corpus cavernosum. Until the patient lost one of his testicles because the injury was also penetrating the scrotum. The management in general, so if it's just a confusion or incomplete disruption in those anterior urethral injuries, you just put a urethral catheter and it solves usually the issue. If it's a complete disruption, you can either do an immediate anastomotic urethroplasty or put a suprapubic catheter and delay it. Now, of course, primary repair is indicated when you have gunshot injuries or injuries that are severe, where you have to go in to repair the organ. Now move on to testicular injuries, which also are injuries that we see. They can occur during sports, MVAs, or assaults. Be penetrating like gunshot wounds, knife, or bomb blasts, or crush injuries. And usually they can be associated with injuries like femoral muscle or perineal, so they can hit the rectum, and also pelvic, abdominal, and chest wounds. So it's a trauma patient. You have to evaluate your patient completely before you focus on the injury which is in the testicle. Sometimes also rarely we see migration of the testicle in the inguinal area, and that's one of the quite interesting story that I had during my training, where I had a motorcycle accident, and the patient came with a testicular, and when I examined his abdomen on the left inguinal area, I felt a mass, and it was a very painful mass. So basically, when I examined the genitals of the patient, the scrotum was empty on that side, and sometimes from the force of the injury, you can have the testicle move to the inguinal area. Well, luckily the testicle was protected. There was no injury to the testicle, but it's quite an interesting story, and you might see that. So beware of always examining your patient and examining also their genitals if they have abdominal pain and inguinal pain. So usually they come with severe pain. They have nausea and vomiting, and there is a hematoma around the testicle. So the testicle might not be palpable. So it's good to do an ultrasound in those cases. So you have a hematocele. Hematocele is usually when you have bleeding in the parietal layer. So this is usually managed conservatively. unless the hematocele has increased in volume, and the volume of the scrotum is more than 3 times the size of the other side. So if this is really an expanding hematocele, then you have to explore and drain. Otherwise, you might have compression of the vessels and ischemia of the testicle by just compression, so compartment syndrome. So this is why you need to explore them. This is here a case where you have a breach of the tunica albuginea. So this is a fracture of the testicle, and you have a hematoma. Here you need to explore and to repair, so debride whatever you got and repair the testicle. This is, for example, on ultrasound, you see intraparenchymal hemorrhage within the testis. So this is an indication also for surgery, for exploration. This is a little bit a graphic here image that I'll show you, and I will end with that. I'm sorry that this is the last image that you will see. This is here from the riots that we have, not the riots, but from the, if you want, the revolution that we have been seeing recently. And this is an unfortunate young patient who has been shot at close range by a rubber bullet. And as you see, this is the image from in the emergency room. The testicle is inexistent, so has been completely shattered. So he ended up with an archaeectomy. And we found inside the wound the bullet rubber and the encasing of the bullet. So this means that he was shot on very close range. So even sometimes with rubber bullet injuries, you can have severe injuries. And well, unfortunately, we had to debride, remove his testicle. The patient is doing well. He has another viable testicle, and he's doing fine, fortunately. And I will conclude, by telling you that, kidney injury is the most common urological trauma, and I think I've said it. It can be sometimes life-threatening, but 90% of kidney injuries can be managed conservatively. So in the ureter, these are rare, but we see them more, in surgical complications, but you can see them in trauma, and they should be managed surgically in most of the cases. And most of the cases, they're associated with other injuries. So this is why, usually, since you're going in for another surgery for bowel or controlling of bleed, then you have to repair the ureter. Bladder injury, if it's extraperitoneal, usually don't do any surgery. If the patient is not going to be explored, just put a catheter and drain the bladder. Urethral injuries also can be managed in a delayed fashion, especially that are associated with major, pelvic trauma. And usually the pelvic trauma is here the main management, so dictates the main management, and then you would do a delayed intervention for the urethra. Testicular injuries, usually we explore them and we repair them. Thank you very much. I hope I haven't given you too much information in a very short time. And if you have any questions, please don't hesitate to ask me. Thank you.
Thank you, Dr. Al-Hajj, for the very informative lecture. It was an absolute pleasure having you with us. Thank you, everyone, for joining us today. We will now be taking questions. So there's one that asks, I don't know if you answered this, but if there's still a role for the Mitrofanov technique.
Well, usually not in injuries, not in in bladder injuries. Mitrofanov usually is used, for as actually you use a part of the appendix. So the appendix, you use the appendix of the patient, and you put it out on the skin. So it's like a mini stoma where the patient can do self-catheterization from the Mitrofanov. So usually this can happen in urological patients who have hypotonic bladder, don't want to self-cat. So these are the patients where we use the Mitrofanov, but not in the cases of trauma. But yes, we still do it.
Thank you. Any other questions? Okay, so there's a comment that says that thank you for the great comprehensive session.
Thanks a lot. Thank you, everyone. Thank you, everyone. Really, I think this is a very nice initiative, and I really congratulate you for this series, really. It's very interesting. I saw the program, and I think it's very comprehensive. And as I said, unfortunately, I think our, predecessors, let's say the older generation, unfortunately had to deal a lot with trauma. In Lebanon, I hope we won't have to see more cases, but it's very important to know these the management of these cases, the diagnosis and management, because we are seeing a lot of trauma patients recently.
Right, but thank you, because this series wouldn't have been possible without all our speakers. So thank you for that.
So thank you all for your comments, really. So I think I said it all if there are no questions, but really don't hesitate. If you have any question, either Twitter or on my email, so you can reach me anytime, or on my pager. So I'm available if you need anything or have any questions.
Great. So thank you everyone for joining us today. This was Jan Ghanem, Met3 representative. Thanks again, and we'll see you in the next session.
Thank you very much. Thank you, Jan, and thank you everyone. Have a nice evening.